Zollinger-Ellison Syndrome, or ZE syndrome. Essentially, this is a gastrinoma that is essentially a tumor that occurs in the pancreas, and it produces gastrin. And gastrin leads to the stimulation or production of increased gastric acid, and this causes stomach ulcers or peptic ulcers. So that's the most brief summary of ZE syndrome. So let's talk a little bit about a gastrinoma. A gastrinoma, as the name implies, is a gastrin secreting tumor, and it's produced or found in the pancreas. Now, gastrin is a very important hormone that stimulates the secretion of gastric acid. This gastric acid is secreted by the parietal cells that are inside the stomach. Well, excess acid in the stomach that is being produced because of the excess gastrin is going to lead to stomach ulcers, and in particular peptic ulcer disease. And the patient's symptoms essentially will be epigastric pain, and this epigastric pain is pretty severe. It's described sometimes by the patient as burning or gnawing type of a pain. The patient may also have coughing associated with it, and these ulcers can sometimes perforate and also bleed. And about 50% of patients with ZE syndrome will also have symptoms of diarrhea along with the peptic ulcers. One thing that's really important to remember is in about 50% of cases of ZE syndrome, you also have some syndrome known as MEN1, and MEN1 essentially is multiple endocrine neoplasia. Now, what that is, very briefly, is a set of tumors that occur in what I like to remember as the 3 Ps. It's tumors in the pancreas, pituitary, and parathyroid. So the pancreas tumor is what's causing the ZE, but you also have 2 additional tumors in MEN1. And the parathyroid tumor produces excess amounts of parathyroid hormone, and if you remember the mechanism of how parathyroid hormone acts on the body, it increases calcium levels, so the patient will have hypercalcemia. So how would you go about diagnosing this? The best test is a serum gastrin level, and it will be oftentimes very high, greater than 1,000, whereas most people are hovering about 150. A test that you can do to check the ulcers is an EGD, and that looks directly into the stomach and the duodenum to see if there's any ulcers. Now, of course, we're talking about a tumor, so you need to do an imaging test to localize the tumor, and that imaging test is an abdominal CET, and that will help to identify the tumor in the pancreas. And then a lot of times, because of the symptomatology, a lot of physicians will do a Helicobacter pylori test, and the reason is because H. pylori can also cause very similar symptoms, so that test is also done. But in ZE, the test will be negative because that's not the main problem. In terms of treatment, the very first thing you want to do is suppress the acid, because there's just so much of it, and that is done with a proton pump inhibitor. And proton pump inhibitors are very commonly used. One of the most commonly used, of course, is omeprazole. Another medication that you can use to decrease the gastric acid is octreotide. And then when it comes to the tumor, it really needs to be surgically removed. And if you have an unfortunate situation where metastasis has occurred of the tumor, then the patient will have to be treated with chemotherapy. So let's take a look at a few vignettes. Patient complains of daily burning epigastric pain of 4 months duration. He states that he is sometimes awakened at night by coughing spells and a burning in his throat. He has also been having diarrhea. Basal acid output using a nasogastric tube is measured to be 15 milliequivalents per hour, and normal is less than 5. An antral biopsy is negative for H. pylori. Fasting serum gastrin is measured at 1,000, and normal being less than 150. Which of the following is the most likely explanation? Well, the fact that his gastrin is so high is really an indication of gastrinoma, and along with the symptoms, he definitely fits the picture for ZE syndrome. Next question. 39-year-old man comes to the office because of gnawing abdominal pain and diarrhea for the past 2 months. He states that the pain is worse about 3 hours after a meal, and it often wakes him at night. He says surprisingly the pain is relieved by food. He takes an NSAID every couple of weeks for headache or backache, does not smoke cigarettes, has a couple glasses of wine on weekends. He vaguely recalls that his father and brother had similar symptoms in the past. Physical exam shows epigastric tenderness midway between the xiphoid process and the umbilicus. There is no rebound. You prescribe amoxicillin, bismuth, and metronidazole and tell him to return in 2 months. He returns for his follow-up appointment and says that his diarrhea is still present and that the abdominal pain has not decreased in intensity. Physical exam is unchanged. Lab studies show hypercalcemia. At this time, most appropriate management is. Well, what the doctor initially did right here with those 3 meds is treat him for H. pylori, because that's one of the more common scenarios that will cause these types of symptoms, but it didn't help. Now, what's interesting in his labs is hypercalcemia. Why is that happening? Well, if you remember, ZE syndrome, about 50% of the time, is associated with MEN1. And MEN1 is a tumor in the pancreas, pituitary, and parathyroid. And the fact that he has a parathyroid tumor is what's causing him to have elevated PTH, and parathyroid hormone essentially acts by increasing the calcium level in the blood. So it's a good question. And I think the best thing to do is investigate a possible ZE, and that will be done with the serum gastrin level. Choice A. And finally, 40-year-old white man has been treated for peptic ulcer disease for several weeks. He also has diarrhea, a problem which has not had in the past. He denies taking NSAIDs, either by prescription or over the counter. You treat the patient with a 3-week course of a H2 blocker, ranitidine, but the patient's symptoms only slightly improve and recurred fully within days after discontinuance of the drug. You then prescribe the hydrogen pump blocking agent omeprazole for 3 weeks with similar disappointing results. An EGD then demonstrated a large ulcer distal to the duodenal bulb. During the procedure, studies were done for H. pylori that were negative. Which of the following would be the next logical action? Well, he's definitely got an ulcer in the stomach, and it hasn't been helped with these basic medications such as ranitidine or omeprazole, and his H. pylori is negative, so you have to think of some other etiology. And a very basic test that you can do without too much expense is a serum gastrin level, so that would be choice A.